persons, dear guests. I didn't expect to have senior attendees to this session. I'll try to be on time. I'm going to talk about the algorithm, or mainly about the metabolic bone disease. Of course, the old terminology used to be renal osteodystrophy, which we are not using anymore because there is a very strong relationship between the disturbances of the minerals and the occurrence of cardiovascular morbidities. And this has actually been noticed very early as 1969, when there was a description, various descriptions in many articles in the literature about gangrenous lesions occurring in uremic patients, and at that time it was not really undermined or addressed. Why was this happening? Some key facts I'd like to go through. That CKD is an international public health problem affecting around 10% of world population, and cardiovascular disease, naturally, as we all realize, is a leading cause of death for our patients. And maybe through the cardiovascular problems, we have vascular and valvular calcifications that are strongly associated with this cardiovascular morbidity. Along with the occurrence of these cardiovascular morbidities, we find the abnormalities in calcium and phosphorus and PTH and so forth, vitamin D, may have a relation to the occurrence of these problems affecting the heart. Changes in the biochemical abnormalities related to the metabolic bone disease phenomena may start as early as stage 3, and the rate of change and severity of these abnormalities vary from patient to patient. So therapy should be focused on correcting these abnormalities. We find that CKD is very difficult sometimes to diagnose because it is a symptomatic disease. Hence, a lot of these patients present by end-stage renal disease, and this was reported in Australia, more than 90%, and this number showed no improvement with time. We had a look at the problem in Al-Azhar, and we analyzed 650 high-risk patients, yielding 10% with stage 5. Diabetics showed a higher prevalence of CKD stages 1 to 4, and the prevalence of stage 5 was higher in the hypertensives, more than the diabetics, showing a 20% to 14%. And naturally, always the low socioeconomic status has an impact. Now, in the year 2009, the scientists Telman Druk and John Cunningham and Sharon Moe decided to put guidelines for the metabolic bone disease through the KDIGO. I'm sure you are all aware of these guidelines. They are published. Just to summarize what it is about, it is saying that the metabolic bone disease is an abnormality of calcium, phosphorus, and PTH, or vitamin D, and these abnormalities lead into bone turnover problems, mineralization problems with linear growth and weaknesses, and also the dreaded vascular calcification that may affect soft tissues as well as affecting the vessels. So you can look at things together in this funnel, the bony abnormalities with the lab abnormalities that may lead to vascular calcifications, would affect the heart, may lead to fractures, and all of these have an impact on the life of a patient. How to diagnose the metabolic bone disease? You need a lab to look at the calcium, phosphorus, and the various other parameters. Radiological assessment by X-rays or electron beams, CT scanning, and then the symptomatology. Let us have a closer look at the vascular or other soft tissue calcification. I just put this photomicrograph to show the soft tissue calcification around the shoulder joint. And it is a really confounding disease, which there is an interplay between atherosclerosis and osteoporosis together with the vascular calcification. They all interlink together through various pathways. Eventually, as you can see, there is calcification of the vessels here, calcification of the aorta over there, and some osteopenia apparent in the vertebra. One of the dreaded complications we don't see so much is the calciflaxis due to the medial calcification of the arterioles feeding the skin. Very serious complication, no treatment. Patients usually get septicemia and may pass through the serious complication. And it's due to vascular calcification again. Now the dreaded one is the chronic calcifications, and we have to do all we can to prevent the occurrence of this picture. We don't want our patients ending with hearts of stone. And the importance of the occurrence of hearts of stone on survival is quite apparent in this study. If you look over there, there is the probability of survival. If you have a zero calcification, everything is fine, and the survival is good. And as the calcification scores go higher, there is a higher rate of mortality. So there is a direct relation between the chronic calcification or the vessel calcification in general and the probability of survival. What's doing it? These are the biomarkers. I will try to address them quickly, the PTH, calcium phosphorus, and so forth, and maybe throw some light on the newcomers, the fibroblast factor and the osteoprotein. And starting by the PTH, I guess we all know at the beginning of the disease when the renal mass decreases, we have decrease in the production of the calcitriol, and there is phosphate retention. Eventually, all the pathways would lead to a hyperparathyroidism over there. And this hyperparathyroidism will lead to various problems related to the effect of parathormone on the bone. If you are suppressing the PTH, fearing the complications with excessive PTH, if you are suppressing it too much, you may have another serious disease we should avoid, which is the low bone turnover disease. And if you are not doing anything about it, you have the high bone turnover disease with the classical osteitis fibrosa cystica. We don't see that frequent anymore. You may ask me, how aggressive should we be in managing PTH or PTH? If you look to the standard KDIGO guidelines, they want to keep the PTH in this range of 150 to 300, and as such, the cardiac and non-cardiac mortality are more or less equal. And now, if you look to the left-hand side of the graph, as the PTH starts to rise, we have a rise in the cardiac mortality. So it is quite evident that hyperparathyroidism is directly related to cardiac mortality. And the extreme of the graph with levels as high as 900, you have really quite highly significant increase in the cardiac mortality. So there is a strong relation between hyperpara and cardiac mortality. But there are some caveats when it comes to PTH. Do we think that PTH assays are so precise? Do we think that the results for PTH suppression are the same for all patients? Well, when we compare the PTH assays to the standards by the KDIGO, we find a lot of conflicting publications saying they do not. And when they have been compared to the standard testing by the Allegro Institute in France, and these are 3 different assays for 3 different levels, 150, 300, and 1,000. Look to the other techniques. It is really so confusing that you could get such results. Not only this, but ethnicity also has an effect. African Americans may be more resistant to PTH than others and may resist higher levels. And in this cohort of patients, if you start to suppress their PTH to the accepted levels recommended by the KDIGO, for example, you could be doing harm to the patients. This is the KDIGO. I'm not going to discuss so much because, as I said, it's all published, but just to emphasize that they suggest that the PTH level should be in the range of approximately 2 to 9 times. If you suppress more than that, there is the dreaded low turnover bone disease. Phosphorus, very serious. The original trade-off that what we were taught in the School of Medicine with the decline of the GFR, there is phosphate retention, then there is a state of hypocalcemia and the associated hyperparathyroidism. This is what we were taught. And the phosphate retention does play a very important role in the pathogenesis of hyperparathyroidism, yet the mechanism is not yet well defined. And there is a direct relation now between hyperphosphatemia and hyperparathyroidism through yet undefined pathways. This very interesting experiment by Danda a few years back showed this and underlined this important point. They got two groups of rats, uremics, and they were fed high dietary phosphates, and they looked at the glands. You could find that the rats that were fed high phosphate diet, their glands grew bigger, underlining this relationship between phosphorus and hyperparathyroidism. So here you are, you have another experimental evidence that hyperphosphatemia does lead to that. So in renal failure, we have this relationship between the hyperphosphatemia and the hypocalcemia and the vitamin D deficiency and the associated parathyroid gland enlargement with the secretion of PTH. Let me skip this one. And now people like to look at the situation as a kind of axis between the kidney and the vessels and the bone. The kidney-bone vascular axis is now defined, and I think very soon the KDIGO are going to change the metabolic bone disease into this nomenclature. Now, in this arena, or in our arena of metabolic bone disease, the initial players have been the calcium, the phosphorus, the vitamin D, and the PTH, and lately there's a newcomer and a new player. It may prove to be an important one, the FGF23. Let's have a look at the original proposal of the trade-off. It seems changing now because there is an important physiological role for fibroblast growth factor in this situation, and phosphorus overload now is well documented that it is leading to the stimulation of fibroblast growth factor that may even start to rise very early in the disease, even before the real assays that we use to assess hyperphosphatemia are really there. This is what the molecule looks like. It used to be called phosphatonin and is definitely regarded as a uremic toxin, and it does have also a direct relation to hyperparathyroidism. I don't want to go through details about FGF, but I have to underline that this hormone, in order to exert its action, has to be in conjunction with a specific receptor called clotho, and together this complex is what makes the FGF work, and this clotho is present in various areas in the parathyroids and in the heart as well. Just to show you how important is the rise of fibroblast growth factor, which starts early in the early stages of CKD and reaches thousands times level during stage 5 or end stage. Now, as much as we have things doing vascular calcifications or leading vascular calcification, we also have things or hormones that are inhibitors. We have the matrix GLA protein, the osteoproteogreen, and phytoin A. Now, I'm kind of interested in osteoproteogreen and doing some work at our university related to osteoproteogreen, which is supposed to be really protective. Osteoproteogreen is a key cytokine that belongs to the tumor necrosis factor. It has a range of pleiotropic effects on bone metabolism, endocrine functions, and as well as the immune system. there is an observation that lower levels of osteoprotein in CKD is associated with an increase in vascular calcification. This sounds very significant since it is protective. But strangely enough, in end-stage renal disease, there is an increase in osteoprotein levels, and yet there is an increase in the vascular calcification. This is very strange. One potential explanation for this strange finding is that the serum assays detecting the non-functioning osteoprotein fragments that are normally cleared by the chronic kidney disease, meaning that it is not really high as was thought. Let me skip the osteoprotein and pass on to vitamin D in the sake of time. We have to depart from the previous thoughts that gradual reduction in calcitriol levels begins early due to insufficient renal mass and the insufficient 1-alpha hydroxylase activity, and now the situation is regarded or believed to be secondary to FGF23 excess rather than the original trade-off. There are new insights for all therapies. We've been using inhibitors of the excessive PTH to treat this condition, and now vitamin D is regarded as a remedy for CKD, and a lot of pleiotropic effects are related to the renoprotective effect of vitamin D, cancer, and so forth. Not only this, there is a lot of emerging evidence that it may be helpful in prevention of progression, so we may use it, but always have your eye on the levels not to over-suppress the PTH. It may be even helpful in preventing fibrosis and blocks the RAS system in diabetic nephropathy. Let me take you back to phosphorus and ask, how aggressive should we treat it? We have to treat it so much, very much. Why is that? If you look again to this graph, you will find when the serum level of phosphorus is within the normal levels, we have an equality between cardiac and non-cardiac mortality. Going to the left-hand side of the graph, you find as the levels of phosphorus increase, the cardiac mortality is increasing. There is a direct relation between phosphorus and cardiac mortality.